Good evening. My name is Dr. David Doman, and welcome to another edition of Housecall. What is the newest information about diabetes mellitus? Find out more right now. My guest tonight is Dr. Paul Sack, Chief of Endocrinology at Union Memorial Hospital in Baltimore. Paul, welcome to Housecall.
Thank you so much. I'm really glad to be here tonight.
Well, thank you so much for joining us. Briefly tell our viewers about your professional background.
Sure. I'm an endocrinologist, which is a specialist in hormones, and specifically we deal with a lot of patients with diabetes, thyroid disorders, pituitary disorders, and adrenal disorders. I did my training at the University of Maryland throughout, so started with medical school, then residency, then fellowship. And I joined the faculty here at Medstar Union Memorial Hospital in 2005. I enjoy seeing patients, getting to know them, and helping them manage their diabetes.
Very interesting. So give our viewers a sense of how bad is the problem nationally, and for that matter, locally in particular, with dealing with diabetes mellitus. How many cases are there out there?
Yeah, so the most recent data says that 11% of the population has type 2 diabetes, which is 37 million people in the United States. And of that, over 8 million, just based on statistics, have it but don't know they have it yet. And that's one of the biggest problems we have, are the patients who come in late and not understanding they had it and already have complications. And then if you go to the pre-diabetes, we're looking at almost 100 million, which is over a third of the population with pre-diabetes. But if you go to elderly groups, so over 65, you get to 50% of them have pre-diabetes. So it's a huge burden. In Maryland, again, it mimics the national data. It's about 12% of Marylanders in the adult population have type 2 diabetes. So again, huge burden of disease. And when you look at it in concert with the rates of obesity, the epidemic of obesity directly is correlated with the epidemic of type 2 diabetes.
Very troubling. So share with our viewers the different types of diabetes out there.
Yeah, I mean, there are two main types, and of course, there's always nuance in this. But the main two types we call type 1 and type 2. In the past, other names have been juvenile onset or adult onset, but type 1 and type 2 is the convention at this point. Type 1 diabetes, we think about typically in the younger population, somebody who is of good health and suddenly gets sick and the sugars are extremely high. And this is most of the time from an autoimmune condition. That is, the body's immune system somehow gets triggered, gets tricked, and destroys the cells that make insulin. And they're pretty much on insulin for the rest of their life. And let me compare that to an older patient who might be heavier, have high blood pressure, have cholesterol, and their sugars start to slowly go up. And it can be a course of years with pre-diabetes, then going to diabetes on one medicine, then two, then three. So it's a much slower progression. But still with really bad consequences. In that situation, there is not enough insulin, although there is some. Again, with type 1, there is really no insulin. And it's interesting that there is some overlap. We are identifying more frequently than we had realized that autoimmune type 1 diabetes happens in adults. So there are patients who are mislabeled as type 2, end up, when we do the correct testing, end up as type 1, which helps us target the treatments.
If somebody has type 1 diabetes, what are some of the potential manifestations of that, besides the ones you mentioned?
Yeah, I mean, anytime the sugar gets really high, and that, again, that is sudden in onset most of the time with type 1, but it can be something that lingers in somebody with type 2. Anytime the sugars are high, we think about the 3 Ps, which is polyuria, polydipsia, and polyphagia, which are fancy words for drinking a lot, urinating a lot, and hungry a lot. And what's interesting in that situation is a lot of times people are actually losing weight in these situations when the sugars are high, where you expect if they're drinking this much and eating this much, that they should be gaining weight. And with that comes, profound fatigue, listlessness, like just not wanting to do anything. And eventually, you figure it out, but patients can go on for a while just with these non-specific symptoms before they get diagnosed.
Now compare that with presentation for type 2 diabetes.
Yeah, so I mean, one of the interesting things about type 1 is you pretty much are clear about at least the week of diagnosis, maybe the month of diagnosis. With type 2, it is a slow process that could be decades of the making, from kind of just a little bit of a high sugar, we call prediabetes, into kind of slightly higher sugar as diabetes, and then slowly getting out of control. And because there are not symptoms in the very beginning, patients on average, when they haven't been getting regular checkups can have diabetes for about 7 years before diagnosis. So a lot of times the way to get diagnosed is not by symptoms, it's by blood work. Again, by the time you're having symptoms, and that might be blurred vision, again, the thirst, increased urination, unusual weight loss, profound fatigue, it's really advanced at that point, potentially with complications already.
And what are some of the complications of type 1 and type 2 diabetes?
Yeah, so just the complications of high sugars are kind of across the board for whatever diabetes you have, which can be affecting the eyes, affecting the kidneys, affecting the feet, and also increased risk of heart disease. So specifically with the eyes, again, this is one of those diseases where if you don't get checked regularly, by the time you have symptoms, the damage is nearly permanent at that point. So you get bleeding in the back of the eyes caused by the high sugar levels, which causes vision impairment. If we can get to it ahead of time before the bleeding gets bad, treatments can be done by the ophthalmologist to fix that. Same thing for the kidneys. We can do blood tests and urine tests to catch kidney disease in the very beginning and at least try to slow it down, if not stop it. When patients aren't getting monitored regularly, they can be in kidney failure before they know they have any kidney problems. Feet. So one of the most common complications of diabetes is what we call diabetic peripheral neuropathy, which is, again, just a fancy word for numbness, tingling, burning of the feet. Usually it starts at the toes and kind of slowly works its way up. And this is caused by years and years of high sugars. You add that to somebody who also may have high blood pressure, high cholesterol with the high sugars, and now you start to get blockages in the arteries, especially the large arteries going to the feet. And that ends up with diabetic foot ulcers because the patient doesn't feel the rock in their shoe or the thumbtack in their foot, and you get an ulcer and they don't realize it because they can't feel it. And then that ulcer doesn't heal because they don't have the good blood flow down there. So the combination of the neuropathy plus the peripheral vascular disease is really, really sad because a lot of times it ends up with amputations. And then finally, it's the whole heart attack, stroke disease that is a huge burden in anyone with diabetes, again, type 1 or type 2, which is dependent on how long you've had diabetes, what the control has been like, and then what these other comorbid diseases are, the blood pressure, the cholesterol, smoking history. Again, diabetes is one piece of that pie that results in heart attacks and strokes.
Well, given so many organ systems that can be badly damaged by the diabetes, you still need to make a compelling case for early diagnosis and early therapy.
Yeah, and so the recommendation for at least for screening, and there are a couple different ways to think about it, but everyone should be getting an annual checkup, even when they're younger, and especially patients at risk. So that would be patients with a family history, patients with obesity, patients with other diseases like high blood pressure, high cholesterol, anyone with symptoms. They should be getting a blood test for this. And if you're super healthy, fine, every few years. If you're not, you need to be getting checked yearly at the very least. There's a couple of different ways to do the testing. So one way is with a glucose, a sugar. And on a blood draw, we have a number. And we kind of have a normal range. And the normal range for anybody who has not eaten, so let's say you go to the lab in the morning, get your blood drawn, you've been fasting for 8 hours, it should be under 100. If it's over 100 and nothing else is going on, like you're not sick, you're not on steroids, there's nothing else going on, that is abnormal. If it's over 125, that is diabetes. There are other ways that we can do the testing, which we don't do as much anymore because it's just really annoying, but you can do what's called a glucose tolerance test. And women who've been pregnant are used to this, but you basically get blood drawn, drink a really disgustingly sweet orange drink, and then get blood drawn 2 hours later. Or if someone comes in and they've eaten recently, you can kind of use the same thing. Again, so we said 100 before you eat, it should go no more than 140 at 2 hours after you eat. Between 140 and 199, that's prediabetes. Over 200, that's diabetes. So that was the way that we used to think about diagnosis in the past, and there was all these caveats. But another way is to look at another test that gives us an average glucose over the last 3 months. And those people with diabetes know this hemoglobin A1c. That's a very common term that we're used to. But basically, it's a marker of how sugar has affected your red blood cells. And red blood cells last about 3 or 4 months. And the more sugar you have in the system, the more they're going to affect the red blood cells. Therefore, this percentage of red blood cells affected will go up. So we just have certain markers. If you're normal, it should be under 5.7%. 5.7 to 6.4 is prediabetes. 6.4 and above is diabetes. And then we have all these kind of other kind of ways to use that in terms of our goals for treatment once we know someone has diabetes. There are again some patients where that hemoglobin A1c is not accurate. And so we have to be careful as physicians to interpret that appropriately. So sometimes it's good to have both. You have the sugar that day, but you also have then the last 3 months to look at.
If you diagnose type 1 diabetes, let's say in an adolescent, there's clearly a growing consensus this is an autoimmune condition. Before you consider so-called conventional therapy for diabetics, is there any enthusiasm within the endocrinology community to treat that as an autoimmune disease?
Sure, and actually there are ongoing trials on this, and there was a drug that has not gone to market yet, but it's close. The issue is when the diagnosis has been made that 90 to almost 100% of the cells that make insulin are already destroyed. So really what it comes down to is identifying patients before that destruction happens, or at least at the early stages. And so there are trials going on where, let's say you have a parent with type 1 diabetes, known type 1 diabetes, they enroll their kids, and there are certain blood tests that can be checked that is a marker for that autoimmune process. And if you get to those patients early, there's a couple different medications, then theoretically you can decrease the chance of it going on, or at least maybe prolong the time that you don't need insulin. But again, the problem is most patients who get type 1 diabetes do not have a family history. You think about type 1, again, autoimmune would be family history. That would be the one that you'd have to really worry about. But if you look at that, it's maybe 10 to 20% of kids get type 1 diabetes when one of their parents had it. If you look at type 2, if you have one parent with type 2, it's 40%. If you have two parents with type 2, it's 60 to 70%. And obviously that's not all genetics. A lot of it is, but some of it is learned behavior. I mean, it's like any chronic condition. It's what the genes show, but also kind of how you learn to eat, exercise, just think about kind of health concerns. So again, it's hard to prevent type 1 diabetes because you can't really pre-identify patients very easily.
In an ideal world, how often would children get their sugars checked to try and screen them quickly?
Yeah, I mean, in an ideal world, they go for the yearly physical, but a lot of times they don't need blood work. They're not symptomatic, so they really wouldn't get it.
So if somebody is diagnosed with type 1 diabetes, what are their treatment options?
Sure. I mean, you need insulin to survive. We actually just passed the 100th year anniversary of the discovery and human use of insulin. That was in 1921. So before that, if you were diagnosed with type 1 diabetes, you would go on a very low carbohydrate diet, and you would kind of slowly starve to death and then die of high sugars. And that might be a few weeks or a few months, but not much longer than that.
Paul, I'm going to ask you to hold the thought.
Okay.
We're going to pause for a public service announcement.
All right.
More with Dr. Paul Sack, endocrinologist and diabetes specialist. We'll be right back. We're back. My guest this evening is Dr. Paul Sack, noted endocrinologist, Medstar Union Memorial Hospital in Baltimore. And our topic this evening is update in diabetes mellitus. Paul, when we paused for the public service announcement, we were just about to discuss insulin treatment for type 1 diabetes. Tell us more.
Yeah, so what we try to do with our patients with type 1 diabetes and our patients with longstanding kind of advanced type 2 diabetes is as best as possible mimic the natural insulin production and how the body would normally do it. And that was not possible for a while. As I was mentioning before, the discovery of insulin was about 100 years ago, but back then they had rudimentary insulin that was from animals. And then eventually they started making it kind of, without that, they had a different technology to make it. But as we've gone along, we've gotten better at kind of dividing our insulin out into two kinds of insulins, which is a long-acting insulin and a short-acting insulin. So you have to know a little bit about basic physiology of how the body works. We all have a liver, and the liver does a lot of things. But from an endocrinologist's perspective, the most important thing the liver does is it makes sugar. And it needs to make sugar so we don't die when we stop eating. And this sounds crazy, but our bodies are made to resist times of famine. We store up energy, which is why we overeat, we get fat, but so that when we don't have food, we turn it back into sugar, and that happens to the liver. So let's pretend we're not in a famine, but we're sleeping overnight, or we have to skip lunch because work got busy. We have a liver that turns our stored up energy back into sugar. And in somebody without diabetes, their pancreas makes just the right amount of insulin to match the sugar coming out. And we haven't really said this yet, but what insulin is doing is it's opening up channels, or like a door, to all of the parts of the body that need sugar, because sugar is the main energy that keeps the body going. So the liver is making sugar, the pancreas is making insulin at the perfect amount at the perfect time to keep that glucose, that sugar level, about 80, 70, 90. And so if you're not eating, you need a fairly flat amount of insulin from coming out of the pancreas. Well, if you don't have a pancreas that works, we need to give you an insulin that kind of takes care of that background requirement. So again, 1 shot a day of an insulin, and there are several out there that do that. So a shot every morning, a shot every evening. And we have to make adjustments because everyone's different. We can base it on the weight. So a bigger person like me might need more than a smaller person, but it's a little bit of trial and error where we kind of see, we give you this much, what are your sugars? Again, targeting around 100. Well, that's fine as long as you never ever eat again. That's the only insulin you would ever need. But as soon as you start eating, and especially when you eat things that turn into sugar, now all of a sudden, again, going back to the normal physiology of the normal body, the body would say, oh, food's coming in, we need insulin. So the pancreas, bam, makes insulin immediately at the perfect amount at the perfect time. And again, our job as physicians, and then the job as patients, is to figure out how much insulin that is for that meal. So there are other insulins that instead of being flat once you inject them, it comes in quickly over about 15 minutes and then kind of goes away over about 3 to 4 hours, which is fairly similar to how the way the body makes insulin for meals. Again, it comes out of the pancreas and then goes away. The pancreas is really good at getting this right. And even with these technologies, trying to get the right amount of insulin at the right time is hard. So the basics are, when we have a brand new patient insulin, we kind of just get them on a basic dose just to get them out of trouble. But then we start getting more fine-tuned, and we start teaching them, getting them to our diabetes education specialists about looking at their meals, figuring out how much am I eating, and specifically how many carbohydrates. And carbohydrate is a big word, but all it means is stuff that turns eventually into sugar. So that can be sweet, that could be a piece of fruit, that could be your regular soda, that could be bread or pasta or potatoes or corn. All of those things eventually turn into sugar. Your body needs insulin to match that. So we can then teach people based on measuring or weighing, an app on a phone, and counting up those carbohydrates. And then based on kind of our experience and the patient's trial and error, giving them an exact amount of insulin to take for that exact number of carbs. So if they have 30 grams of carbs and I tell them, look, your carbohydrate ratio is 10, then they take 30, they divide it by 10 and they get 3 units and that's what they take for the meal. And it can be really, really complicated and confusing, but necessary because again, we're trying to mimic this natural physiology. So patients with type 1, we have to be really, really precise. Patients with type 2 who need insulin, but they're still making a little bit on their own, we have a little more wiggle room. So that's what we can do, injections multiple times a day before you eat a meal. What's really exciting about diabetes, at least in my mind, is just the advent of technology. And insulin pumps started coming out in the early 1980s, but really have taken a bunch of leaps and bounds technologically in the last 10 years or so. So instead of doing all of these shots, we put insulin into an insulin pump and we trickle it in, and this is getting confusing, but we trickle in this short-acting insulin over a long period of time, and that gives you that flat amount of insulin. And then on top of that, the patient can just press some buttons. I'm having 30 grams of carbs. We preload that carb ratio of 10. So the pump knows the math is 3. And so then it gives 3. Well, that's pretty good. But then what if the sugar is high or what if it's low? How do you adjust that? So then the patient starts to have to do all these calculations in their head. What's then happened in the last 4 years is some great technological advances in continuous glucose monitoring. We really haven't talked about checking the sugars. In the past, it's been prick your finger, put it on a strip, see what it is. Now we have a couple of different monitors, and you may have heard of Libre or Dexcom. Those are the 2 most popular that are continuously monitoring the sugars. And now you have a continuous monitor and you have an insulin pump, and you can start to close this loop so that the patient is kind of taken out of the equation. And now the pump and the continuous monitor are talking. So there's some automatic adjustments that are happening in the background, even when the patient's sleeping or just not paying attention. Right now, the ones that we have, you still have to count the carbs, you still have to enter in that data, but then again, the pump will kind of give you a little bit of wiggle room, so it will add or subtract. And these new advances have made diabetes much more manageable. I will never say easy because I don't have diabetes. I know what my patients go through, but this technology is really, really revolutionary.
You mentioned the pump. What about these injections that are given once a week? What are they for?
Sure, and a lot of people get confused because they hear injection, they think, well, this is insulin, and it's not. And again, without getting into too much of the minutia of the physiology, there is a hormone that comes out of our intestine when we eat. And specifically when we eat any of that carbohydrates that turn into sugar. And as soon as our body starts to detect sugar coming into the intestine, bam, this hormone is released. And again, this is one of the reasons why the body works so well when it's working right, because it detects that sugar's coming in, the insulin starts to come out right away. Well, you can imagine in patients with type 2 diabetes, that system doesn't work very well anymore. So that connection between the gut, which is bringing in these sugars, and the rest of the body that has to deal with it, it's broken. So there are ways to manipulate that system in a way that helps the patients. And this hormone, which is called GLP-1, only lasts a few minutes in the body. One set of medicines are pills that help stop that breakdown. So instead of only lasting a few minutes, it lasts a few hours. And they're pretty good. They're not really strong, but they're pretty good. Or there are newer medicines now that basically give you a mimic of that natural hormone, but they last much longer and they give you way more of this hormone than your body could ever make. So again, the natural effects of this hormone are reduction in appetite, decrease in the time, it keeps the food in the stomach longer so it doesn't come in rushing in at once. It gives the off signal to that liver. Remember, I told you that liver is just cranking out the sugar. It needs to be told to stop when you're eating. And it gives the on signal to the pancreas. If that system doesn't work, you have these huge rises of sugar after you eat. If you can just give a lot of that hormone, and again, it's similar, it's not exactly that hormone to the body, it really mimics that. So appetite reduction, weight loss, early fullness, the sugars come down overnight because you're not making as much sugar, and you really get a much better insulin release naturally, not with an injection, but naturally the body makes its insulin at a better time, better amount to keep the sugars from really spiking after you eat. And people are aware of Ozempic, Trulicity, those are the weekly ones. It started out with a twice a day one, then it was a once a day, now there's a once a week. I know they're working on once a month. And there's even one now that's a pill that is taken once a day that's very similar to one of the once a weeks. And what's really interesting is that now these medicines are being marketed to patients without diabetes just for weight loss. So we know that these medicines help with weight loss, and they actually even help more with patients who don't have diabetes who need to lose weight. So these medicines have a lot of benefits. There are some side effects. One of the benefits besides the glucose reduction, so the A1c comes down, you lose the weight. They've done studies now showing about a 15% decrease in heart attack, stroke, and death. So you're not only giving medicine for diabetes, you're also treating all these other problems that we've already talked about that go along with uncontrolled diabetes.
There's been a lot of interest over the years, even decades, about islet of Langerhans, the source of insulin, being transplanted. We have a couple minutes left. Share with our viewers what you think is the potential role of that transplantation.
I mean, this has been going on for decades. So just like you can transplant a kidney or a liver, from a deceased donor, you can transplant a whole pancreas. And so for somebody with type 1 diabetes, this is a really good option. Because again, if you can get a pancreas into that body that's going to work, I have patients who've had that transplant and they don't have diabetes anymore. Again, this is for type 1. For type 2, it just doesn't work. Okay. They've also tried to kind of isolate cells that are from the pancreas and inject it into the liver. There's been too many complications and not enough benefit. And there is some research into kind of creating fake cells and using those, but we're not there yet. I mean, we're getting closer. And, patients want to know, like, is there a cure? And for type 1 diabetes, theoretically, the transplant option is a cure, but there's a lot of complications going on with transplants, and they don't always last very long. The best we have for type 1 diabetes right now are those pumps that I told you about that really do take a lot of burden off the patient. For type 2, we're really not talking about cure. We're talking about trying to find the right medicines that are going to work for the patient to help their sugars come down, not going too low, but also kind of mitigate some of these risks that we talked about: heart attacks, strokes, kidney disease, et cetera.
Dr. Sack, thank you for an excellent interview.
We had a great time. Thank you. We could spend another few hours talking about.
Absolutely. That's the best interview. Always leave the viewer hanging for more. My thanks to the team at the station for making this program possible. And my thanks to you, the viewer, for inviting us into your home this evening. Tell us how we're doing. You can reach me at my Medstar email listed on the bottom of the screen. As for our next show, it's going to be fascinating. We'll be talking about update in the newest therapies to treat prostate cancer. Today, with this broadcast, we celebrate our 9th anniversary on the air, and we're still going strong. See you then next time for another edition of Housecall. Good evening.